Hello, my name is Ailec Estrada, and today I am presenting my DMP project on the implementation of a CGM training checklist in type 2 diabetic patients that are not on insulin and its effect on A1C levels. Introduction. The prevalence of diabetes has been on the rise in recent years, especially in the younger population, and glycemic control has been on the decline, leading to more increased risk of complications at an early age, which in turn it can increase the rate of disabilities and expenses to the patient and the healthcare system. Non-pharmaceutical self-management recommendations have been created to have the patient in charge of their decisions to improve glycemic control. Continuous glucose monitoring devices motivate the patients to change their lifestyle decisions on diet and exercise based on a more easier and practical ways of checking their blood sugar readings without affecting their day-to-day activities. CGMs, or continuous glucose monitoring devices, offer the patients and clinicians the ability to observe and evaluate glucose changes, trends, and patterns that help make safer treatment decisions and/or change their diet choices. The American Diabetes Association and the American Association of Clinical Endocrinologists have provided new addendums to technology guidelines to include the beneficial use of CGMs on type 2 diabetes. These devices measure glucose continuously every 4 to 5 seconds in their interstitial fluid. The data is then sent to a transmitter and it can be seen on a receiver, reader, or a smartphone. Patients can also share their information with family members and their clinicians for input and recommendations. Personal CGMs are currently only covered by many healthcare agencies for type 2 diabetics if they are treated with multiple daily insulin injections, if they wear insulin pumps, and if they check the glucose readings at least 4 times a day for insulin adjustments. And this must be proven by providing blood sugar logs to the insurance companies. Continuous glucose monitoring devices continuously check for trends and can predict low and high values, alerting the patient for imminent hypo or hyperglycemic events. These safety features help decrease the patient's anxiety, improve quality of life, and increase treatment compliance, leading to an improved glycemic control, which it can be observed in the reduction of their A1C levels. Kraborusik 2020 talks about the REPLACE study, which it shows that CGMs in patients with type 2 diabetes decrease the time in hypoglycemia by 43%, making it very statistically significant. In addition, Thomas 2022 mentions how the use of CGM significantly reduced the A1C levels by 2.8 to 3%, with some patients reaching an A1C of less than 7%. This reduction in A1C directly caused reductions in secondary disease outcomes, such as in obesity, cardiovascular disease, anxiety, and increased quality of life and patients' overall well-being. The purpose of this scholarly project was to increase awareness of continuous glucose monitoring devices and show the many effects that they have on glycemic control with the use of diabetes education and the implementation of a training checklist that could be used by medical assistants, diabetes educators, nurse practitioners, and/or physicians when studying any patient on continuous glucose monitoring devices. The PICO question is as follows. In adult patients with type 2 diabetes, how will standardizing diabetes education to include the use of a continuous glucose monitoring device education checklist compared to no education on CGM improve A1C levels in an 8-week period? This project was a quality improvement project that took place in an outpatient endocrinology clinic. The data from the project was gathered from electronic medical reviews of type 2 diabetics 18 years of age or older. The patients that were seen at the clinic that met the inclusion criteria for the diabetes educational training checklist interventions were selected for the chart reviews. The clinic had been offering diabetes education by the certified diabetes educator without a standard protocol. The patients that were seen in the clinic for diabetes treatment were then referred to a diabetes educator at a later appointment that took weeks, months, without having a standardized educational protocol. The implementation of this CGM training checklist is offered by medical assistant with sufficient knowledge to start the patient on CGMs, and this was offered on the same day of their follow-up visit. They will follow up with a training checklist after being appropriately trained. This also saves time for their A1C to show an improvement. The intervention consisted of the following: an in-service to medical assistant and certified diabetes educator was completed by the principal investigator. Patients were offered the CGM service and the training completed on the same day of their visit, guided by the checklist to guarantee that all the participants were receiving the same level of care and the information needed. Patients were linked to the clinic's account so that providers could access the patient's data and monitor the progress. The pilot project determined the successful implementation of this checklist by helping standardize the training process at the clinic and guaranteeing patients were educated on the safety features and in turn improving disease outcomes and preventing complications. The inclusion criteria included the following. The electronic medical records had documentation that the adults were 18 to 89 years of old. The electronic medical record had documentation that participants were diagnosed with type 2 diabetes only. The EMR had a documented A1C level pre-intervention. The electronic medical record showed that participants were not on insulin treatment. The electronic medical record showed an A1C level of less than 10. The electronic medical record showed continuous glucose monitoring was started the day of the visit, and patients received training and education verbally based on the intervention checklist. The electronic medical record showed a follow-up visit at the clinic with a documented post-intervention A1C level. The exclusion criteria included the following. No data was reviewed if patients were less than 18 or older than 89 years old. No data was reviewed if A1C levels were above 10. No data was reviewed if patients were on insulin. No data was reviewed if patients were type 1 diabetics. No data was reviewed if patients did not have a follow-up appointment in 8 to 8 weeks with a documented post-intervention A1C level. The pre and post A1C levels were then recorded and analyzed using the statistical program called a Statistical Package for the Social Sciences, or the SPSS. The university statistician was consulted and guided the calculations. The independent variable was the education checklist, and the dependent variable was the A1C scores. The data was scaled, and a paired t-test was used for the analysis. The paired t-test is used to compare the means of the two data sets and show if the change in the means is statistically significant. In this test, the data is collected from the same individual, but at different times, with a pre- and post-measurement after the intervention is completed. The A1C levels were analyzed, showing the mean, median, standard deviation, and skewness. The pre-A1C and post-A1C were also represented in figures 1 and 2, shown below. The pre-A1C shows the frequency of A1Cs pre-intervention with a mean of 7.47, while the post-A1C shows a different frequency with a mean A1C of 6.85. The parity test results from the data analysis show significance as a one-tailed test since the p-value was less than 0.001 was less than the level of significance of 0.05. The effect size was 0.932 and the power was 1. Effect size measured the difference between the pre- and the post-test measure in standard deviations. The power of 1 therefore represented a very strong power for the study. There is evidence to say that the A1C scores went down after the implementation of the checklist, suggesting that a well-educated patient on a continuous glucose monitoring device can improve their A1C levels independently of the treatment changes. The study successfully increased awareness of these devices for both providers and patients. Increasing this awareness led to providers giving the patient the choice of using continuous glucose monitoring devices, instead of only recommending them if covered by their insurance, which was a great additional benefit from this study. Many patients then decided to self-pay for these devices after they saw the positive effect of CGMs on their disease outcomes, even if their insurance did not provide any coverage. The project strength of this project included the elimination of selection biases by performing 43 electronic medical chart reviews that met the inclusion criteria, independently of ethnicity, gender, or income. The use of A1C levels to measure diabetes control. It provided a valid and reliable assessment measurement. The glycated hemoglobin, or A1C, in the blood provides the average glucose levels during the previous 2 to 3 months, making it the most common test to show diabetes control. The project limitations of the study was the sample size. The sample size consisted of 43 patients' electronic medical records. Therefore, a much larger sample size is needed in order to generalize the results. The limitations can suggest potential ideas for further research. More research is needed on the impact of CGMs on type 2 diabetic patients that are not on insulin, for insurance carriers to perform policy changes and improve the coverage for these devices. Clinical practice and future research. The outcome of the study did not only help increase patient awareness of the continuous glucose monitoring devices, but it also helped motivate the other providers in the clinic to increase the recommendations to all diabetic patients, including patients that are not on insulin at the current time. The standard standardization of the training process made it easier for providers by becoming aware of the available clinical resources to provide complete educational sessions to all diabetic patients in the practice, independently of insurance coverage or treatment regimen. This QI project also promotes the idea of the ethical concept of justice, where it implies that it is important to give the patient the choice to use these devices and not for an insurance policy to decide for them. Furthermore, this project helped to observe the benefits of CGM in this population of type 2 diabetics that are not currently using insulin by proving that their A1C levels did improve significantly. Improving disease outcomes leads to saving the healthcare system additional costs related to hospitalizations and preventing the addition of more expensive anti-diabetic medications that could also lead to more adverse effects. The findings of this project serve as a base for more similar studies with a larger sample to generalize the results. Future research is needed to prove the additional benefits of lowering A1C levels, such as improvement in secondary outcomes, such as decreasing in body mass index and improvement in cholesterol and quality of life. For healthcare policy, this scholarly project calls for policy change to increase the coverage of continuous glucose monitoring devices in type 2 diabetic patients that are not using insulin, by showing how this population can also benefit from CGM's benefits and help decrease additional unnecessary healthcare expenses. The current policy provides coverage for only type 1 diabetic patients or type 2 diabetic patients that are on insulin, requiring monitoring their levels more than 3 times per day. Therefore, this study calls for a more universal coverage that does not restrict the CGM usage based on type of diabetes or treatment regimen. The plan for sustainability of this project. A continuous glucose monitoring training checklist was implemented in the practice to be carried out by the medical assistant and/or diabetes educator, with the purpose of standardizing the training process. The leadership department has become aware of the results of the study and were able to see that patients had improved their disease outcomes as evidenced by improvements in A1C levels. And in addition, patient satisfaction scores were increased. Ultimately, quality metrics that involved A1C improvements were largely improved to meet Medicare guidelines. The continuous glucose monitoring training checklist involved minimal costs. Therefore, it has been largely accepted by the clinic administrators. It has been added to the onboarding process of medical assistants and diabetes educators, and the expectation of these medical assistants, guaranteeing that CGM training checklist will stay as part of the training process in the clinic for years to come. Plan for dissemination. A continuous glucose monitoring device training checklist should be implemented in every endocrinology clinic that offers CGM training. A well-educated patient on the benefits of safety features of CGMs can improve their disease outcomes by increasing their control of their disease symptoms and manage their diabetes by changing their lifestyle and improving their diet and exercise routines, become more compliant with their treatment, and their anxiety can decrease over possible side effects of medication. Recommendation from this study is to have a well-prepared trainer to assist with CGMs and provide providers with the necessary clinical resources to improve the quality of care. The next step in recommending from this study would be to include secondary measures to continue to prove the benefit of CGM, such as the impact in body mass index and lipid panel, suggesting a decrease in cardiovascular risks. And these are my references for the study. Thank you very much.